Okay, let's get started here. So hi to anybody that I don't know. My name is Jenny Cartwright, and I'm a member of the BC Support Unit, the Vancouver Island Centre. I'm the Island Centre's knowledge broker. I'm going to be moderating this poster presentation session, which basically is just going to involve making sure that we're on schedule. And I'm coming to you today from Victoria. So I'm on the traditional and unceded territories of the Lekwungen speaking peoples, and in particular the Esquimalt and Songhees nations. So I just want to acknowledge my presence here as an uninvited guest on their territory. So we're going to flip the script slightly because we only have 5 poster presentations in this session. So we have a little bit of wiggle room. So what we're going to do is we're actually going to have questions after the posters rather than saving them to the end. So we're going to have about 15 minutes on each poster. That will include the presentation and any time for questions. And then at the end, that should give us about an extra 15 minutes. So if there's any further questions that we haven't got to, we will get to them then. The fabulous tech support person, Zach, has given people co-hosting privileges, so the presenters are going to share their own screens. And if there's any issues, which hopefully there won't be, we will sort them out. So we're going to start off with Jennifer. So if you are able to share your screen, that would be great. And I will give people a reminder when we get to about 9 minutes in the chat box. So if you see anything pop up, it's probably just me. And then we'll have some time for questions afterwards.
Great, thanks very much, Jenny. Hi, everyone. So I'm really looking forward to sharing with you today our project that was looking at how patient-reported outcome measures might serve as a tool to support adherence in the setting using a falls prevention clinic. Before I start, I'd just like to give a huge thanks to the BC Support Unit and the Health Economics Simulation Methods Cluster. See Nick Vance back here, he leads the cluster as well, for supporting this study. So what we'll do is I'll start off with the presentation, and then Daria, who's a trainee, will continue to go through the methods and the discussion with you. So I'll start with 2 things we know that help motivate the project. What we know is that patient-reported outcome measures are increasingly recognized for their role in primary care clinical settings. And another thing we know is that some of the benefits, some of the health and other benefits that patients might receive from interventions can sometimes be limited due to a failure to adhere to some of the recommendations. So our goal for the project was to examine how patient-reported outcome measures might be able to support patients' adherence to recommendations that patients receive at a falls prevention clinic. So just to highlight briefly, this clinic serves a frail population of older adults who often have mobility as well as cognitive impairments, and it operates in Vancouver. We included 21 older adults who had been former patients of the Falls Prevention Clinic. So they had a lived experience of receiving care from the clinic. And we conducted focus groups in sizes of 4 to 6 using semi-structured interviews. And our analysis included coding at 3 stages using open, axial, and selective. Now, Daria, I'll stop sharing and hand it over to you.
Thanks, Jen. I'm sorry, I'm just gonna pull my notes. Can everyone see? Yeah.
You just might want to turn up your volume, Daria.
Oh, yeah, sorry. Can everyone hear? Okay, so I'll just be going over the results and discussions. So the findings of our studies are summarized into 6 general themes based off of the questions we asked our participants. And through their answers, we identified the predominant and sub-themes, and we wanted to highlight a few of them. So under theme 1, we found that for usefulness of the patient-reported outcome measure, or the EQ5D5L, which is what we focused on, many of the patients identified that there could be many opportunities that can arise from using these, the PROM, and mainly they expressed that there is opportunity for the provider to gain more of their own perspective of their condition, and there's opportunity to help them gain self-awareness, as well as for comparison purposes. As one patient expressed in the key quote, they think it could encourage them if they know they're improving, or if they're slipping, quote, it might give them a little kick in the back, unquote. So for the second theme, the EQ5D5L administration and feedback timing, a key quote pretty much summarizes the majority of the responses, where one would find it helpful to have their provider go over their responses with them on the day of. So in other words, many preferred more frequent administrations in a real-time manner. Under theme 3, tracking health status over time, the relationship to adherence, the patients identified some of the benefits and challenges that could come with this. For the challenges, they thought that there may be potential difficulties in interpreting the proposed graph that summarizes this data, but most of them did identify that the potential benefits that come with it could be that it could be a source of motivation for them if they're able to see any improvements over time. And again, using it as a comparison to better understand their treatment process is also seen as potentially useful for them. So under theme 4, comparison of PROM data with peers, most of them found that it could be useful for them to gain more self-awareness by knowing how they compare with their peers, and also be a potential source of motivation for them. Under theme 5, patient perspectives on promoting their own adherence, we asked them if there were any other information that could help them promote their adherent behaviors. And most of them highlighted that getting direct feedback from the provider would be most useful for them. So having the provider directly talk to them about their adherence behavior may be helpful. And finally, under theme 6, the potential role for the EQ5D5L in promoting adherence. Again, there were both of the perspectives of having a potential role and also maybe not as helpful, but for the patients who express that they may not have a role in promoting their adherence, they're more likely to say that they know that about their own state of well-being, and that that kind of information may be more helpful for the provider. And for the reasons that could help them change their behavior is, again, improving their self-awareness and using that to guide their own behaviors, and having it as a potential source of positive reinforcement if they're able to see that they're improving. So I just wanted to highlight one of the key quotes for the last thing. Quote, "The reason I want to see the long-term answer sheets is I'm curious to know whether the exercise program that I've put myself through is changing any of these answers as the year progresses. And so that seems to me that that would be a really good feedback to adherence," unquote. So to summarize, I'll go over the 3 take-home messages from our results. First being that our results highlight the importance of productive provider feedback to facilitate patient understanding and to promote self-awareness, as these are the sub-themes that consistently come up over the these 6 themes. Second is that patient experiences are dynamic and should be recorded frequently to capture this. And this was seen through their expression of wanting to have the EQ5D5L administered more frequently and getting real-time feedback from that. And lastly, it can be a useful tool for providers to gain a patient's perspectives on their conditions, record any trends, increase their self-awareness, and potentially assist in directing the provider's treatment plan. Thank you for listening, and that is our presentation.
Thanks so much, Daria and Jennifer. Does anybody have any questions for the presenters, either in the chat box or you can just unmute yourself and ask them?
I'm wondering if I should keep my poster up or...
Yep, sure.
I have a question. I'm just wondering, I think you had mentioned something about how so the patients are able to kind of look at their information and see their progression over time. How does the clinic share that information back to patients?
Daria, can you just share briefly to answer that about the graphs that you showed the participants in the focus groups?
Yeah, so we proposed to present that data using a graph that plots their responses from the questionnaire over time. So on the x-axis would be the each follow-up appointment, and on the y-axis it's the range that that the EQ5D5L provides according to their responses to the questionnaire.
Okay, so you do that for them so that you do the analysis like on their behalf as time goes on and report back that data to them for each individual person?
Yeah.
Okay.
Yeah, so just to clarify, Heather, so that's not a practice currently being done. So we were exploring basically a practice that uses that model in the clinic, which kind of relates to Nick's question about what are your plans for the future based on these findings. So our future plans are to incorporate some of the key findings regarding frequency and real-time feedback and come up with a model to try and test the implementation of that in the clinic. Due to the pandemic, the clinic operations were actually ceased, so things are just restarting. So we're looking forward to exploring that in the future.
Cool. Yeah, no, it could be really cool. It's very interesting how people are choosing to kind of share essentially like private confidential patient data back and forth between the clinicians and the patients to kind of do this you know, like collaborative model of care. It'll be quite interesting to see where you go with this when you're able to.
Yeah, and I should highlight that when patients come into the clinic, they sign a consent related to this. So patients that don't sign the consent obviously don't participate in that component. Yeah.
Any further questions from anybody? All right, well, we're probably going to have some extra time at the end. So if anybody thinks of a question, just hold on to it or put it in the chat box and we'll come back to it at the end. So thank you very much, Daria and Jennifer, for that. I will get Tsion to share her screen hopefully now. Excellent.
Okay, There we go. I hope you can all hear me and see the screen. So thank you so much for everyone who has joined today. My name is Tsion, or Tsion in English, and I'm very excited, albeit nervous, to present on this research project, which is entitled Understanding Research Experiences Among Persons Identifying as African, Caribbean, and/or Black in British Columbia. And going forward, I might just use the acronym ACB, but that means African, Caribbean, and/or Black. And before we get started, I just want to acknowledge that I am an uninvited settler here on the lands, the ancestral territories of the Coast Salish peoples, which includes the Musqueam, the Tsleil-Waututh, and the Squamish nations, on which we have the privilege to learn, collaborate, and work. So to start off, I just kind of want to give a bit of a background as to how this project came to be. It is pretty new. So this specific project is actually kind of a sub-project under a greater provincial study, which is looking at the health and aging of women living with HIV. It's the BCC3 study, or the BC British Columbia Karma Chivos collaboration study. And Karma and Chivos were two cohort studies that looked at healthy aging and the health of women living with HIV. So just to give you some background there. And so in these two studies specifically, we have had some difficulties in engaging women living with HIV who identify as ACB. And so through some conversations with our community partners and our research team, we kind of developed this project that is looking at these research experiences and understanding that racism is a social determinant of health, which contributes to this underrepresentation. One of the aims of our project will also be to kind of explore these barriers and hopefully find some facilitators as well to meaningful engagement, which ultimately we hope will foster more research participation and also anti-racist practice for researchers in general. And so the table here on the right-hand side is just kind of looking at these statistics, the underrepresentation of ACB persons in research, but their overrepresentation when it comes to different health conditions like HIV. And of course, as we know, Canada doesn't really do the best job of collecting race-based data, so it's actually, this is quite incomplete, but we do know that racism is the social determinant of health that does propagate health inequities. So just to go over some of the aims, sorry, also I'm just trying to go through the poster as well here so you guys can see a little bit more clearly. But so the research aims really are to build research capacity among ACB women living with HIV, but also to, while exploring these research barriers and thinking of ways to kind of facilitate and encourage this meaningful participation, we ultimately hope that we can help researchers to adopt anti-racist practices within their research studies going forward, and to really use more community collaborative approaches to foster that meaningful engagement. And so in the middle here, the graphic that you see are the guiding principles of our research project, CHIPA, MIWA, and CBR. So the meaningful involvement of women living with HIV/AIDS, the greater involvement of people living with HIV/AIDS, and then community-based research principles. And so for our project, it was really developed by, with, and for ACB persons, including ACB women living with HIV, which really, again, is so important to fostering those meaningful relationships and participation in research, but also for setting those priorities, those research priorities together to make sure that we are really helping to address the inequities that do exist in research. So this project has two main aspects, which will be a workshop and a survey. So as I mentioned, because it is still a pretty new study, we are still getting started in our data collection stages. And so both of these aspects, the workshop and the, sorry, I hope you can't hear the siren. Sorry, the workshop and the survey have both sort of been adapted for COVID restrictions. So our workshop, which initially would have been held in person, will be a virtual workshop that we'll be holding. And so the main purpose or the aim of the workshop will be to help build research capacity among ACB women living with HIV. And this will be done in partnership with one of our really critical community partners, which is ACPNet, or the Afro-Canadian Positive Network of BC. And so we'll be looking at things like participant rights, and informed consent, ongoing consent, sorry. So really building that research capacity within ACB women living with HIV. And also just to give another bit of background, sorry, ACB leaders in our communities here in BC have kind of suggested that part of the reason that we see this underrepresentation is due to unfamiliarity or distrust with research and researchers, as well as stigma. So this workshop hopefully will help to address some of those things. And then the survey will be more widely disseminated throughout British Columbia with some of our partner organizations. It is a self-administered online survey, and it will really be looking at those research experiences in the past, what kind of contributed to those experiences, whether they were positive or negative, and then looking at barriers to research participation, as well as facilitators for meaningful engagement. And so the inclusion criteria for this would be that the participants must identify as ACB, must be 16 years of age or older, and then also residing in British Columbia. And so again, this community collaborative approach will really extend throughout the process. So already throughout our development stages, that's how we came to the point where we are now. And then for data analysis, dissemination, and or rather dissemination, data analysis, and knowledge translation activities, we will also be doing that on an ongoing basis with our community partners. So just to discuss some of the anticipated impacts, we've identified some immediate or short-term impacts, as well as some more long-term or more broader impacts. So in terms of immediate term, because this project is within the BCC3 study looking at healthy aging of women living with HIV, we hope that the workshop as well as the survey will help to recruit a greater diversity of women, but also greater numbers of ACB women within the study as participants, but also through our community advisory board, which will help to guide our project, as well as our peer research associates, which will actually, who will be involved in the data collection aspects of the BCC3 study. So again, building capacity is one of those aims and those impacts in the short term, but also in the long term or even more broader than that, not necessarily just for health research or research related to HIV, but more on a broader scale of research in general. We hope that the results of the study will help to really inform those anti-racist practices and help researchers to build and foster those more meaningful relationships with our communities and who are implicated in the research we're doing. And as we know, we can't have research without our community or members of our community. So it's really, really important to foster those relationships, which ultimately means that we are trying to work towards improving and increasing equity within research for these different groups, and here specifically for ACB persons. So yeah, those were the greater or more broader impacts. And so I would like to just end by thanking the BCC3 research team, individuals of the CHIWOS research team, as well as my supervisor, Dr. Angela Kaida, without whom really this project would not have been possible, but also their ongoing support and encouragement is really also very vital for the success of this project. So thank you to them. Thank you for everyone who has come here. And with that, I will just turn it over to you if you have any questions. I can also keep my screen up to help that. Thank you.
Thanks so much, Tsion. If anybody has questions, just unmute yourself or put them in the chat box and we can read them out.
Thank you, Tsion, for your presentation. Are you hearing me?
Yes, I can. Thank you.
Yes, I was wondering in terms of if you've identified some of the main facilitators that would help you to have a good recruitment rate or good response to your survey.
Yeah, so again, we're still pretty early in those stages, but some of the things that have been suggested, at least by ACB leaders within the community, is really increasing that capacity. So understanding research participation, so in terms of like informed consent, and then benefits to the research as well is really important, because a lot of the time, I think as participants, we are not really always made aware of the benefits of the research, what implications that could have for ourselves as individuals, but also for our broader community. And again, having that underrepresentation in terms of, programming or interventions that exist seen that underrepresentation is also a deterrence from participating. So those are some of the things that we're trying to address. Within the survey, we also are looking at things like language barriers, cultural barriers, things of that nature, stigma, and again, that unfamiliarity, with research as factors as well that need to be addressed.
Thank you. I would propose that you also look into respondent-driven recruitment methods, that you can have individuals who participate and work, because this seems to be a very specific group of people that might not be very large in BC, and so they're likely to somewhat know each other and might not be so I would propose that you look at different respondent-driven sort of recruitment methods. For example, people who complete the survey, tell others, and there are methods that would include incentivizing people for both completing the survey and referring others to complete the survey. So I would propose that you look into those ways as well to reach this sort of community of people.
Thank you so much. Yes, definitely. Actually, thank you. I think maybe I didn't answer your question properly, but that is actually something that we have included for the survey, for example. There's like a prize draw at the end for a gift card, and then we have many different community partners within BC that will be helping us to disseminate that survey. And so we do also encourage people to really use like their personal networks, professional networks to encourage more participation. And so we hope that we will have a good response rate. But thank you so much for your comments, they're very valuable.
I have a question. I'll have a question for everybody, I'm sure. But I was wondering a bit about, so back to your kind of patient-oriented research and patient engagement approach and working with the ACB communities as partners. I'm wondering if you can tell me a little bit about how that's been for you, and what type of advice you would give a white settler who isn't necessarily like a white outsider, I guess, who's kind of wanting to work with these communities as patient partnerships. If you have any advice around that.
Sure. Okay, I'll answer your first question first. I'm so sorry about the siren.
I live downtown too. It's all good.
Okay. I just want to close the window there. Okay, so for the first part of your question there of how we found it to collaborate with our partners. So some of them are partners that have kind of, we've had these partnerships with them for previous studies like CHIVOS, for example. So these are like ongoing relationships, but I've also done a little bit of my own personal like networking and reaching out to different individuals, different organizations that serve ACB communities. And I really find that having this personal connection and really, building interpersonal connections, I think is really the biggest part of it. So when you present yourself, not just as a researcher, but as another individual, and really focusing on meaningful engagement, I think that has been really helpful for us in our, like currently as I'm working with different partners. In terms of advice, I think really the values and the principles behind your research will help to kind of speak to that. Because again, like when we're thinking about unfamiliarity or distrust with research, it's because the way that researchers interact with these communities has not really been very positive, or it's very much more extractive. So I think it's really about presenting your research and creating your research as well from the beginning with those community partners, and also maybe allowing communities to set their own research priorities. So it's not just, we're not coming into it, we think you want to know about this and this is what we're going to do, but rather actually having the community involved in developing the project itself and setting those priorities. And that way it creates a much more meaningful involvement, and then also having that throughout the entire process and not just at one stage or the last stage or something like that. I hope that kind of helps or answers your question, Heather.
Yeah, no, it's a great job. I know it's a tough question because this is all about building relationships, and it's challenging to build relationships and scary if you're not sure how someone else or how another group that you're not familiar with will receive your attempt to build a relationship. So, but your work is really interesting. So thank you for sharing it.
Thank you so much.
Yes, thank you so much, Tsion. We will come back to more questions at the end if people have them. For now, we're going to move on to the next presentation. It was going to be by Jude Kornelsen, but Jude has had to step away for an urgent meeting. So we've got a couple of co-presenters who have stepped into the breach. So I will ask them, do you guys have the ability to share your screen? Excellent.
Can everyone see this?
Yes, we can.
Awesome. Okay, I think Ava, you'll start off.
Sure. Hi, everyone. I'm Ava, and Gal and I will be presenting on behalf of Dr. Jude Kornelsen and the rest of the Center for Health Research, as well as our 4 patient partners who were involved in this project on capturing out-of-pocket costs for rural residents in British Columbia who have to travel to access healthcare. So first of all, I would like to just acknowledge the HESM cluster funding and thank you for supporting our project. So just to provide a little bit of context for the project, at the Center for Rural Health Research, we do many focus groups and interviews with rural residents. And throughout our fieldwork, we've heard how big of a concern out-of-pocket costs are for people who have to travel for care. And at a systems level, healthcare decision-making does not include the costs that patients have to incur when traveling. So as you can imagine, this is particularly an impediment for patients from vulnerable populations. Especially for those who need ongoing chronic care and diagnostic procedures, less so for emergency care, which there seems to be better supports available for. And so we really wanted to better understand the barriers people face just by virtue of rural citizens face, just by virtue of having to pay to get the healthcare that they need. So our methodology is patient-centered. Like I said, it began with respectful listening of rural residents' concerns. And then in collaboration with our 4 patient partners who all reside in rural communities across the province, we co-developed a survey to capture costs related to different thematic areas for rural residents who have to travel for care. And the survey had both qualitative and quantitative components. I will just speak briefly to our qualitative findings and then pass it over to Gal. So there were 3 questions in the survey where patients could answer open-endedly about their experience traveling and accessing care. And these comments can be summed up thematically. The first one related to transport. So in particularly, we heard from rural residents who live on the islands and their challenges taking ferries, which fill up very quickly in the summer and they don't have priority on to get to their medical appointments. We also heard, for example, along the lines of transport, patients who live in northern or interior British Columbia and face really quite extreme weather conditions during the winter. So people spend a lot of money on flights to get to their medical appointments, and then they're canceled last minute because they can't fly, and there's no kind of mechanism in place to be on standby or to get a refund. And then even more generally, people with chronic conditions who rely on their car or a family or friend member's car to transport themselves to their medical appointments after traveling many, many kilometers over years. As you can imagine, this has a big toll on, a financial toll on their vehicles. So the second theme is related to psychosocial effects of traveling for care. Again, not surprising when we think about the populations who are going to travel for healthcare at a referral center. They probably already have underlying anxiety or stress about their medical condition, and then this is compounded by the challenges of traveling for care when they have to maybe worry about being without their support system if they can't afford to bring them with them, or missing work, or just exasperated worries related to leaving their home community to find care. Thirdly is the physical effects of traveling for care. Again, not a surprising finding. One of the comments that spoke most loudly to me in the survey is someone who was discharged from surgery after only staying for 1 night and had to take a crowded Greyhound bus 9 hours home to their home community with a bleeding wound. So just a really uncomfortable experience to be so far away from your home support kind of in all manners, financially, psychosocially, and just physically from a comfort level. And so finally, that brings me to our fourth kind of qualitative theme, and that's delayed or diminished care seeking. So we heard from many residents who decided not to get the care that they were recommended to receive, just because they, for a number of factors, and often for a number of intersecting factors, could not take the journey to get care. So overall, what we heard in the qualitative sections of the survey is that from a structural level, while there are some supports in place, there's overall a huge dearth of support and for rural residents who have to travel for care, and this by far has a disproportionate impact on already vulnerable populations. So I'll pass it over to Gal to talk a little bit more about the survey itself.
Thanks, Ava. So yeah, the patient partners, first of all, affected, they provided input on both how we presented our survey, what the survey structure was actually like, and also the analysis as well. And one example that I will give is we were looking at the questions, we were trying to look at the reported stress per kilometer traveled, and we were trying to get a measure of what, on a Likert scale, 1 to 10, what the stress level was, or whether it increased for every additional kilometer traveled. And patient partners, provided us with the insight that, a lot of the more financially stable rural residents, rural healthcare patients will likely fly. So even though they will have a really high number of kilometers traveled, their stress level won't be as high. So we ended up moving towards looking at the stress disparities for the different income categories, and that was really elucidating. So we found that, higher income rural residents experience less stress. So that was an interesting finding, and that kind of reflects a lot of what these findings are showing us, is that if you're in a stable position, if you're retired, or if you have a steady income, then traveling to seek healthcare in a referral center or in Vancouver is not going to be as much of an ordeal as patients who are more vulnerable, which is what we'd expect. And yeah, so it was nice to have the patient partner perspective. We ended up reevaluating the survey in December because of notes from them. I can provide more examples about how they informed the analysis and the presentation, but I think it'd be nice to just go into some of our findings, because there were a lot of questions. We asked in excruciating detail about different spending categories, from hotel, or how much you spend on a hotel versus BC Cancer Agency accommodation versus hostel, and like the frequency at which people paid for these different accommodations, how many people traveled by bus, how many people traveled by ferry, what percentage of people received financial aid, what was the average amount of wages lost due to having to travel for healthcare, and then an entire section on co-traveler expenses as well. And overall, at every stage, we consulted with our patient partners to see what they thought about our results. And overwhelmingly, we received kind of a reaction of, this is good, but this is almost even an underestimation of the amount of out-of-pocket costs that we have to spend to receive healthcare. And that was surprising for me, because as you can see here, the average total out-of-pocket costs is over $2,000 for respondents to our survey. And so that's not for one trip, by the way, that's for one condition.
I just, sorry to interrupt, Gal. I was just thinking it's important to emphasize it's just for one condition. So for rural residents who have to travel for every condition, this really adds up over the lifespan, and imagine having multiple family members. I think overall, we heard gratitude from rural residents, finally there's some recognition of how much of a kind of social justice issue this is, that we don't have adequate compensation for receiving the appropriate care that we need.
Yeah, and I think this also inspired the Rural Health Network of BC to start a petition, petition the BC government to act on this, which was really nice.
Sorry, Jennifer, I see we have 1 minute remaining, so we'll stop there. And if anyone has any questions, we can answer them now.
Sorry, didn't mean to stop you mid-flow there. There's another 5 minutes or so if you would rather keep going, but it would be nice to take some questions if people have them.
Yeah, no worries. We're happy to answer questions.
Yeah, Eva and Gal, great to see you again. For those that don't know me, I'm the president of the BC Rural Health Network that Eva referred to. What I would like to emphasize is how important this research is to underscore the barriers that exist for people living in rural communities. My wife and I, sitting beside me here in Minka, live rural. We are in the category of the fortunate ones who do not have to worry about paying for to get to our care, but we know of several people that are not in our position. So I encourage everyone that has a concern here to sign our petition to get the government to act on this. And that is really the question. What is it that we would like to see? And perhaps Eva and Gal or Gal, you might want to comment on what you might see as the ways that these barriers can actually be removed for people living in rural communities.
Yeah, thank you so much, Ed. It's a great question, and perhaps I'm not the best person to speak on it. I mean, I see that there's a number of solutions, and I think that traveling for healthcare should always be kind of the last ditch effort. So there's a number of things that we need to see in terms of strengthening resources in rural communities by increasing the rotation of visiting specialists, by increasing the capacities of rural hospitals themselves. And then, of course, there will always be procedures where people will have to travel, just realistically. So coming up with broader structural safety nets to make sure that those people who do have to travel don't fall through the cracks, and that there is both financial compensation from them, but also a broader understanding from the healthcare system in terms of arranging appointments on times that are convenient, and just generally, you know, considering how much of a burden it is to have to travel as a last ditch resort.
And just to add what Eva, to what Eva was talking about financial compensation, one thing that we did notice was that a lot of those people who received financial assistance received it in the form of tax or exemptions, and that's not really useful for, you know, a lot of lower income people who wouldn't be paying that much tax in the first place. So maybe just like Eva said, restructuring those safety nets.
Yeah, thank you for that. I don't want to monopolize here because I know there are other people that want to ask questions, but I think what I really want to underscore here is that people live in rural BC have known about these problems for years and years and years. And what this survey does is it provides a quantitative and qualitative set of evidence to show that this is real. This is not something that is fabricated, and it's something that really needs to be addressed by our government.
For sure. And I just wanted to very quickly respond to Amanda Green's comment about people who live in the East Kootenays and issues with accessing services in Alberta. This is definitely a theme that comes up a lot in our focus groups in the East Kootenays area. And I know that it used to be easier for BC residents to access care in Alberta if it was closer, and now there are increased barriers to interprovincial care. So for sure, this is an area of concern, and we would like to, and we absolutely recognize it in our work and would like to include that in our recommendations for making care for rural residents easier as well.
I was just wondering, I think, like as Ed said, like we've known that these costs exist, but I think what you've done is actually put some numbers on them, which I think is helpful. I'm just trying to think through to sort of really help ministries make these decisions and trade-off choices, sort of whether these are costs at sort of like an individual level, but trying to sort of scale up to try and actually think about what this would mean in terms of budgets and to inform sort of that level of policy making. Is there, can you see a way of like linking these sort of like unit costs with sort of more population data to sort of actually come up with numbers that could inform that sort of budgeting decision making that I think will be important for ministry as they sort of think about this?
Totally. So yeah, it's a big question for us, and it's like a health economics question of putting a monetary value of how much the health system is actually saving by treating people locally as much as possible, or yeah, see, here's the big one. For example, it says 59% of respondents thought traveling for care negatively affected their health. So I guess the question we can ask is, to what extent does traveling for care negatively affect people's health, and how does that translate to you know, the healthcare system and having to invest more in those patients? But yeah, it's a really big question. We're looking at a lot of different costs and system costs, but it hasn't really been done like a cost benefit analysis in such a way, in this way, I don't think has been done before. It's just because we're looking at the out-of-pocket costs of the patients. So it's like, if the question is mitigating those costs, to what extent would that result in mitigation of healthcare costs on a provincial level as well? So thanks, yeah, good question.
So we are out of time. I don't know if you have like 30 seconds to respond to Amanda's question in the chat. Have you thought about replicating the study post-pandemic now that many clinics have moved to a virtual health model?
Yeah, just to answer really quickly, it's a great question. We are hoping to release a follow-up survey. And in terms of, I guess, the virtual health component, which I think is going back to Ed's question about supporting like rural services and decreasing the need for access to care, I think if the pandemic does have a silver lining in relation to our study, or like we see it very clearly that hopefully there will be a greater move to virtual care, and this will lessen the burden on rural residents.
Great, thank you so much for stepping in and presenting on Jude's part there, Ava and Gal. And I will ask the next presenter, who is Vanessa, to share your screen if you are able to do so. And if anybody has questions that weren't answered there, we hope to have a few minutes at the end of all these presentations as well. So Vanessa, are you able to screen share?
Yes, now I am. Just one sec. Okay, could everybody see my screen okay?
Yes.
All right. Hi, everyone. My name is Vanessa Fong. I'm a doctoral student at SFU in the developmental psychology program. So the study I'm going to talk about involved a collaboration with researchers from SFU, from UBC, and of course our parent partner, Bo-Sang Lee, from the Korean community. So I'll talk about his role in a little bit, but just to give some background. So this particular study is part of a larger study, which is part of my thesis, which focuses on quality of life and facilitators and barriers in accessing services for Korean families of autistic children. So autism is a neurodevelopmental disability. It's diagnosed in about 1 in 68 children. It's characterized by challenges in social skills, communication, and repetitive behaviors. Okay, so I'll just jump right in. So we took this preliminary data from my Korean sample and compared the findings with data collected by the second author, Emily Gardner, for her thesis that she collected from a Canadian sample who are comprised of mostly white, high SCS kind of participants. So the purpose of this study was to understand how families define their family quality of life and to compare Korean and Canadian samples and their definitions and understandings of family quality of life. So we wanted to do this because, especially recently, there's been a growing recognition and concern over the applicability of certain assessment tools that are developed in Western contexts and informed by studies comprising of a very homogeneous, again, high socioeconomic status, highly educated, mostly white samples. So this is problematic when clinicians and also researchers use these tools to assess functioning, but they don't include domains and aspects that are valued cross-culturally. You know, they may fail to address and recognize and understand what their specific needs are and what their barriers and challenges they face are. So we had two research questions. The first was, how do Korean immigrant families and Canadian families of children with autism define family quality of life? And we also wanted to look at the similarities and differences and how they define family quality of life. So so some of our methods. So we conducted semi-structured interviews with 13 Korean parents and 15 Canadian parents. And then the data were transcribed and analyzed using a thematic approach, using In Vivo, which is a qualitative analysis software. So now I'll just go into the patient-oriented research elements of this project. I'll mostly focus on the Korean sample, as this was a guiding framework used throughout the entire project. So Bo Sang, he's my parent partner. He's a co-researcher. So he's a parent of an autistic child who's now an adult. He's also the executive director of a nonprofit organization called Here and Now. It's a Korean organization that provides information and support for families, particularly in their community. So they provide information and workshops in their language and things like that. So we met at the very beginning of the study before ethics was done, before we had a research question. So Bo Sang helped identify gaps in the research. He voiced his own and his community's priorities. He helped formulate the research question. He was also very involved in preparing our study documents, in preparing our ethics. He also, oops, sorry, can you hear me okay?
Yep.
Okay. So he also helped in constructing the interview guide and which questions we would answer participants and things like that. He also helped translate some of the documents, so some of our ads, he helped translate them in Korean. So he played a huge role in recruitment. This is a hard to reach community. So he spoke to members of his community one-on-one, told them about the project, gave them background about who we are, what we do, the research that we do in our lab. And he had a lot of really important insights into the methods. He recommended to give the interviews to participants ahead of time so that they can think things over. So things like that. Yeah, and he also co-interviewed the participants with me, so that was a huge help there. So now I'll just talk about some of our findings. So for Korean families, three themes were identified: family cohesiveness, value orientation, and acceptance from society. For Canadian families, themes around family interaction, support, emotional well-being, individual characteristics, and comparisons to other families were kind of essential themes from those interviews with this sample. Some key differences was the Korean families put a greater emphasis on the importance of religion and their faith and impacting their family quality of life. Another thing was the sample also consistently mentioned the importance of acceptance and inclusion in their communities and society. So these aspects are currently not reflected in current assessment tools for family quality of life, despite having a significant impact in this community and how they define this concept. So based on these findings, there are a number of recommendations. So it's important to incorporate diverse perspectives in the development of these types of assessment tools. These assessment tools should assess areas of strength and resilience, and also recognize diverse values and traditions. And they should also be available in multiple languages and delivery formats to accommodate different preferences for communication styles. So yeah, that's kind of it. Does anyone have any questions?
There's a question in the chat box here asking if you could talk a bit about how you recruited your patient partners.
Yeah, hi Brittany. Okay, so yeah, for sure. So it was kind of, the first stage was meeting with our parent partner. We kind of discussed who our sample was going to be. I think we originally intended our sample to be much younger, but our partner had expressed that there are a lot of challenges, especially in adults with autism. There are so many barriers in accessing services for adults on the spectrum. So he recommended that we, increase our age limit to older adults. So once we figured that out, we had an idea of who our sample was going to be. We asked Bo Sang to contact his community first to see kind of if there was interest and things like that. So he talked to a lot of these parents individually, kind of reaching out to them either in person or on the phone. And then he asked, if they were interested. And then Bo Sang sent me like a final list of who was interested. And then I contacted them and gave them a little bit more background into the study and things like that. So that's kind of how we did it. Yeah, did that.
And how did you first connect with Bo Sang? Was that just through a personal connection? Yes.
My supervisor, I think, had worked with him through ACT, another nonprofit, autism community training group. So it's they're based in BC, but they provide information to families all over the place. So I think that's where they met. It was through ACT, and I met him through my supervisor. Yeah. It's a good question.
If anybody else has some questions that they think of, we can come back to them at the end if we need to. But if there are no more questions, we will move on to the final presentation. Thank you so much, Vanessa.
Thank you.
So up next, we have, last but not least, Heather. Are you able to share your screen?
Hi, everybody. Thanks for sticking it out. Can you all see my screen? Is it good?
Yes.
Okay. So yeah, thank you for staying till the end to the final presentation. So if you need to look away, look out the window for a second, stand up, shake yourself out, totally fine. Take a minute for yourself. So my presentation is going to be about a project called Piloting Digital Storytelling for Endometriosis and Painful Sex, Ethical Considerations and Emotional Impact. And so for those of you who've never heard about endometriosis, it affects approximately 1 in 10 people who are biologically female and any gender identity. So 50% of those people do have difficulty with pain during sexual activity, as well as pelvic pain, painful menstruation, painful bowel movements, bloating, nausea, and unsurprisingly, a diminished quality of life. It can take up to 7 years to get a diagnosis. There's no cure, and symptoms continue to reoccur even after treatment. So we as a team, and being the only tertiary care center for endometriosis in BC, recognized that there was a significant need for more information about this condition, particularly for the sensitive subject of painful sex. And we recently created the Sex, Pain, and Endometriosis website, which is launching in October, so this fall. And we presented this at the conference last year. But what we found that the website was missing is a sense of connection, validation, and empowerment. It's still a little too biomedical for us. So we were fortunate to receive a small grant to pilot a digital storytelling methodology to see if we could create content that would fill this void and provide that sense of connection and validation for this condition. So this study is really an acceptability and feasibility study. We're very early into it, so that's why my poster is a little bit sparse. But I do have some data to share with you today. We started September 12th, and we're about 3 weeks in now. So what we're really interested in is understanding the acceptability and feasibility of using digital storytelling. That is a particular method developed by Story Center for this population and the subject matter of painful sex. We want to know what the emotional impact is of participating in this workshop and whether participants are willing to share their stories and create stories that are that don't perpetuate misinformation and that provide that sense of connection as well. So to do this, we used a participatory, patient-oriented research approach. And the workshops themselves are a 6-week workshop of story circles. So people bring their stories, they workshop them with the other people in the group over 6 weeks, and they create their own visuals, they learn the mechanics of creating a story, and they really unpack the deeply emotional components of their story. We're collecting data through observations, a weekly reflective journal, and at the end we'll do a focus group as well. And our approach to analysis is going to be through interpretive description, where we really look at the data as a whole and try to understand what is happening here and what we are learning about this methodology. So we have 7 patient partners who assisted us at were partners with us at various stages in the grant writing and study design. They'll also participate in the analysis, sharing results, and designing a study for a follow-up CIHR grant. And 3 of them chose to also be participants in the study and create their own stories through the workshop. So in total, we have 6 people with lived experience creating their stories. We're also collecting the experiences of the facilitators and 2 of the researchers, myself and the PI. We actually also participated in the Story Center methodology and created our own stories using this methodology before or while we were developing the project, which was a really interesting aspect. I've never this sort of speaks to the quote that I put at the top of the poster. I've never really done that before, put myself in the shoes of participants and actually acted as a participant in a way myself, and it was very eye-opening. So all of our participants had a long history of endometriosis, 5 of which stated that endometriosis was part of their lives for the last 16 to 22 years. A mix of white and Southeast Asian, a mix of heterosexual and bisexual, and 4 had shared their stories before, but 2 had never shared their stories publicly or with people that they didn't know. So like I said, we're very, very new into this. We're only about halfway through the workshop. But what we're finding so far is a really interesting aspect of relatability. So how this methodology works is people give feedback on their stories about, in regards to what relates to them as they go through the story circles. So it's not a criticism of, I like this, I don't like that. It's, what resonates with your story, which helps to create relatable stories. And there are many, many common themes that are coming out of people's specific experiences, like validation with diagnosis, the importance of support networks, loss, hope, and struggle. We're also finding it's a very, very intimate experience. So one of the quotes we got from the first sharing circle was, it's like we all just survived a plane crash and are forever connected, which sounds awful, but it's actually positive. It's said in a positive way in terms of creating a connection between people. And we also heard about this safety in numbers aspect, which I thought was really interesting, that people developed fully formed stories and were really able to deeply engage with their experiences in a small supportive group in a way that they would never be, that I've never seen before in qualitative interviews or focus groups that I've done. So I think there's a lot of interesting potential for this methodology in getting qualitative data about people's experiences that wouldn't normally share their experiences. We certainly found that there was a significant emotional impact. So a lot of discussion about complexity of human emotions, hope mixed with deep sadness, excitement mixed with nervousness, triggers of trauma mixed with intrigue, which I thought was quite interesting. People certainly are struggling with getting through the what's right and what's wrong of telling your story, which is an interesting part of the human condition. And speaking to the type of people and their journeys, endometriosis, significant motivation despite serious challenges that are even more magnified due to the current climate and environment that we're in. We also experienced a number of ethical considerations that will probably become a bit of a methods paper in regards to the dual role of participants and research teams, as well as specific considerations for the ownership of the digital stories. We have a multi-tiered consent process. It's very possible that we get to the end of this and no one wants to share their story publicly, and we'll be exploring what some of that, that means in terms of the research moving forward. And we've already experienced equity barriers to engagement, technological barriers, time barriers, stress barriers, which have been quite interesting to unpack, as well as we prepare for properly costing a future grant application. And we're really excited to see all the rich detail that's come out of the experience that people have had using this method. And our ultimate goal will be to develop a larger project, to develop an innovative and engaging way of creating and sharing health information about endometriosis in a way that empowers people, combats stigma, and validates lived experiences. So that's all I have. I'm happy to take questions, and I'm really interested to find out from any of you if anyone has experience working with the digital storytelling method and what your experience has been.
Thanks so much, Heather. I see that there is a question in the chat box from Ava saying, really interesting approach. Can you talk a little bit more about how you've been addressing barriers to participation?
Sort of. So we're still trying to address barriers to participation, but a lot of this was worked out because the way that we designed the study was that, as I said, the research team, myself, and the PI actually participated in a public version of this workshop. And so we kind of had firsthand experience about some of the challenges, but we of course don't have endometriosis, and we did it pre-COVID. So it's a very different world right now. But I think that was one of the key aspects that really helped us in designing a project that would have limited barriers. But one of the main barriers that we have found is, of course, stress and technology. So one of the ways that we have mitigated that is that we actually have a clinical counselor that is available to support participants throughout this journey. And they're also allowed to bill us back for an individual session as well. So that provides some additional support, and also that person can have a private one-to-one funded session and receive recommendations or referrals to other support if they need that. And the other aspect that we're actually still working on is some people are struggling with technology and coming up with their own visuals. So we're currently exploring how we would get either a film company or a graphic designer to come in and actually support some of the participants with their visualizations. So this is a work in progress, and what I've loved about this study, and particularly I should acknowledge our funders, the BC Women's Health Foundation and the Women's Health Research Institute, and they've really just given us like carte blanche to figure it out. And it has been really quite valuable in that sense that we can pivot this project and we can come up with new solutions as we go. So it's been fun and challenging, but those are some of the things that we're working on at the moment.
That's great. Thank you, Heather.
I had a question myself. I was wondering what encouraged the two people who'd never shared their stories before to share them this time? Like, what was it that brought them forward to share when they never had done?
That is a good question. I don't know. I don't have the answer to that. So we are asking people to complete a reflective journal, and we're 3 weeks into the 6-week story development process. So what we've done is put a focus group at the end, and at the end, we're going to be asking questions like that. And then we've also got a multi-tiered consent process in that people have consented to do the workshop, but they haven't consented to share their story. And then at the end of the workshop, we're going to ask them in what ways they would like to share their story. So they could consent to, nope, it's mine, I don't want anybody else to see it. Or they could consent to, us, just the research team seeing it, a private viewing, or, public on Twitter as awareness campaign for everybody to see. And it's been interesting reading through the reflections because it seems as though people's thoughts change. In some reflections, people are like, yes, I definitely want this to be for awareness raising. And then the next week they'll go, oh no, this is way too personal, I want to keep it to myself. So I'm not sure we're going to know the answer to that until it's all worked out. Yeah, I'm curious to find out. I think it's in development.
Are there any more questions that people want to ask or type in the chat box?
Yeah, so I've just seen this from Daria. Can I elaborate on further on how I will evaluate the effect of their stories? Yes, I didn't include this much in the presentation because it's at a later stage and I was trying to keep to time. But we do actually have a third aim for that. So again, because this is a pilot study and what we're interested in finding out is for those who are willing to share their stories, how well do they resonate with other people? How well do they connect with people outside of the group? So every year, our clinic does something called the Celebration of Hope, where there's about 100 people or so who all have some connection to endometriosis, friends or family or patients. It's a long list. I think usually thousands of people are invited. And we usually get about 100 people. And what we do is it's a knowledge translation event. So we share research findings. We get a guest speaker, often from somewhere else in the world, to share latest research on endometriosis. And then we have like a mix and mingle where, patients or family members can talk to the doctors over tea and coffee. And so what we're planning on doing is for those people who are willing to share their stories, is we'll do a survey at that event this year, which will be online, so it'll be easier to do a survey about how those stories resonate, in what parts of the stories resonate. You know, did they find that there was misinformation, and how the story emotionally impacted them when we screen them at this event. So that's what our plan is for that.
Oh, hi, Heather. This is Dennis from Kelowna. I'm a patient partner from oncology, but I'm very interested in research. I spent quite a bit of time in my first career in research, and what I'd like to know is, what are the expected outcomes of your particular research here?
Yeah, so this is a little bit of a different type of research project, because we're not, our outcomes are to understand the research process. So to understand how this methodology works, and in what ways patients respond to this methodology. So it's a little bit different in that there isn't a specific outcome, you know, related to endometriosis or the disease history. And this is kind of the nature of this pilot study. And so I guess one of the #1 outcomes of this, other than, you know, understanding the methodology, is to develop a better grant in the future. So we want to write a large grant that uses this methodology, particularly to, you know, reach the stories of patients who might not feel comfortable talking about painful sex. It can be very daunting and also very challenging culturally, personally, and for many different reasons. So this is our test run to see how that works. And then we're going to be developing more specific outcomes related to this population. Some of them might be awareness campaigns. We have interest in having a special group that develops stories that target policymakers as well. So it's a difficult question for me to answer, because we're very fortunate to be in this exploratory phase where we can develop our outcomes as we go. I hope that answers your question.
Well, my understanding, you know, from listening is that, you know, you're exploring storytelling as a potential tool for gathering information on the patient experience, or, you know, patient engagement.
Yeah.
And then, you know, the big question comes up. I've sat on quite a number of provincial committees and many short-term engagement opportunities, and I find that, you know, if you keep the outcomes focused and you make sure you communicate that, you know, usually you're more successful. You know, that's all I'm saying. But there's a storytelling component, and then, you know, the question later on becomes, is it a representative sample of the patient voice, so we can make potential changes for continual improvement?
Yes.
So, you know, I leave you with that one. It's, you know, I've been wrestling with this one for a couple of years now, sitting on all these various committees, and how does one come up with a representative sample? Because as a practitioner, you know, as a medical practitioner, I would sit there and say, okay, this is one person's story, I understand. But also, having taught statistics for many years, I know a sample of one is not representative of the population.
Yeah.
So I hope in your research, you know, you continue on with, and then, you know, start to focus on what is a representative sample, to make sure that, you know, there's enough perspectives and viewpoints, so someone can then say, gee, there's an opportunity for continual improvement here.
Yeah, no, absolutely. And this, you know, methodology of storytelling is very new for us, you know, and our team. And we did wrestle, you know, at the beginning with the representative sample. This particular study, we've chosen not to go with a representative sample, It's more of a convenient sample in terms of people that, so they're mostly patient partners that we recruited from, people that we know, and we're well aware and acknowledge that this is not a representative sample, and that wasn't. There are also people who are generally okay with talking about who represent themselves as people with endometriosis. I think there's a lot of work left to be done, and certainly for the larger grant, we wanted to work out as many details as we could with kind of a like a safe group of people that we knew, we wouldn't harm, that we knew well, that we could speak to openly and honestly. And then in the larger study, that representative sample aspect is going to be a big part of it, and there'll probably be a part at the beginning of that study just to understand how we can even access or get a representative sample for sure. Yeah, lots of work left to be done for us.
Well, good luck with it. I feel there's also some overlaps in education, because I've done a lot of research in education, and I've taught for 15 years, and there's a lot of value in the storytelling instrument for education as well as research. So I think you're on to something very interesting. Congratulations. Thank you.
Thank you. I appreciate it. Thank you very much for your comments. It's been very insightful to learn about this project.
Yes, thank you very much, Heather, for that presentation. We've got about 5 minutes left in the session. I don't know if anybody has any questions for any of the presenters that they didn't get to ask earlier, and they want to ask them now. Or we can have a 5-minute break before the next session. Any last minute thoughts from anybody? If not, I will say thank you very much to all of our presenters for sharing with us. Actually, I should turn my video on so you should see who's talking. So thank you very much to everybody. It's been great. Thank you for being here throughout the session. Also, thank you to all the participants who had great questions. And thank you to our fabulous tech support, who luckily Zach didn't need to do very much, which is great. Thank you once again, and I will see everybody in the next sessions.